I'd like to start by mentioning that this post is too long. It's a bit abstract and philosophical, and to be quite honest, I'm not exactly sure it would make sense to people who aren't themselves a clinician and haven't gone through the process of writing down patient stories. Nonetheless, I think this is an important piece in this series that we're doing on medical narratives. And today I would like to discuss what I'm calling the typical medical story arc, and the process that we go through when we convert the patient's narrative into a typical medical story arc. What is a typical medical story arc? Well, I'm considering this to be the narrative pattern of a particular diagnosis. It starts with a standard set of patient symptoms and events that ultimately lead to a specific diagnosis and its subsequent complications. If the diagnosis is to be considered the top of the story arc, many patients who share that diagnosis will have a similar presentation towards the diagnosis and a similar sequence of events after. In the field of diagnostic reasoning, the same idea is often found in the concept of an illness script. And in the terminology, I'm just using a medical story arc because this is a series on narrative language, but really this is very similar to an illness script, if you're more familiar with that term. The common diagnostic approach is to use a pattern recognition technique where the physician will try to fit a particular patient's unique narrative into the narrative arc of an existing medical story that they're already familiar with. And so what happens is physicians will question patients and search for facts that increase or decrease the similarity of the patient's medical narrative that they're presenting with existing known medical stories. And once satisfied that the patient's narrative is sufficiently fitting a pre-existing medical story arc, the physician will then present that patient's story to colleagues and in their documentation, not using the patient's own words and sequencing, but using the structure of a traditional medical story arc. Now, the risk with this approach is overfitting. And by overfitting, I mean the forcing of a patient's narrative into a standard pre-existing narrative structure. So this has the risk of misdiagnosis by latching onto particular aspects of the patient narrative and insufficiently exploring other elements of the narrative, which might have actually led the physician to an alternative diagnosis. And physicians might not be aware of all diagnoses and their associated illness scripts or medical story arcs, which is another risk of this process. And furthermore, a physician's medical story arc for a particular condition might actually be inaccurate or incomplete. And so, therefore, the process of fitting the patient's narrative into a pre-existing medical story pattern at an early stage of the diagnostic process, such as right during the initial interview and during that initial the initial documentation, carries with it the risk of overlooking important facts in that history, in the physical exam, in the diagnostic workup that might lead to an alternative diagnosis. And one of the biggest risks of this whole approach to diagnosis and to documentation is that the story might make sense. And you see, if the patient's story can make sense in the mind of the physician, they'll be satisfied that they've arrived at the correct diagnosis. However, there's a real possibility that the particular facts that they've pulled out from the patient narrative so far may better fit in an alternative story arc, meaning with an alternative diagnosis. There's also a real risk that we may never discover, or only discover too late, that the wrong story arc was used. And for this reason, we are often stop searching for alternative story arcs once we're satisfied that the story arc we are writing is complete. When we write our notes as physicians, we'll include all the details that we need to tell a particular story arc. And long as it seems comprehensive to us, we'll think, as I mentioned, that we've got into the right diagnosis. However, we might in that note have looked over some facts which are in fact very important to the patient's particular story, but because we didn't think they were relevant to the story arc we were writing, we might completely leave them out of the note, even if we heard those facts or observed those facts. And so this gap between what the patient's narrative actually is and the clinical documentation that we write can sometimes be quite large. And so this is yet again another reason why expert physicians often prefer to re-interview patients themselves and may often disregard a lot of what they find in the written chart when dealing with complex or undiagnosed patients. Well, the problem is that when you consider the question, can physicians survive without medical story arcs, the answer is probably no. Medical story arcs are such an important way that we think about the course of an illness that we naturally start to use this reasoning process right from the start when we encounter a new patient. And the alternative to using story arcs is not much better. A common critique of medical students, sort of junior residents, is that when they present a patient's narrative, it is often a series of discrete and non-connected facts. They often present a lot of information, but they don't lead the listener, such as the attending physician, throughout the documentation into a comprehensive and cohesive story. And this makes it very hard for the listener to know what facts to pay attention to and which to potentially disregard. And therefore, the medical student will often be instructed and coached to present their case so that the patient's presentation fits into the arc of a known medical pattern. This makes it easier for the attending physician to ingest the story they are being told. But as we discussed, this also carries with it the risk of being told a story that sounds right but is not actually the full patient narrative. Now, Larry Weed proposed a solution to the bias created by using the medical story arcs to drive diagnosis and documentation over half a century ago. And at that point, he advocated the use of standardized patient questionnaires, standardized data collection methods, and standardized data presentation methods. This isn't to mean that we ask the patient only a series of yes and no questions, but it's to ensure that there's a standard set of questions which will always be collected and a standard set of data which will always be collected almost regardless of what we think the primary story arc might be. And so this approach minimizes the risk of overfitting the patient's story to a preconceived medical narrative, and he claimed that this systematic and comprehensive approach would often uncover certain aspects of the patient's health history that would often be missed when a more focused approach, driven by searching for the facts required to fit the patient's story into a existing patient story arc, is used. Let's conclude this. This one's really long. The recording, there's two approaches to history taking and medical documentation. You can take a very focused approach where you essentially seek out trying to fit a patient's story into an existing story arc and almost stop once you've satisfied that search. Or you can take a very systematic and very broad approach, perhaps as proposed by Larry Weed. My general impression is that a more standardized approach to the history and documentation steps will more reliably lead to the correct diagnosis and avoid the errors of entering into diagnostic reasoning too early on with the wrong diagnosis in mind and really trying to fit all the data into a particular story arc. And so we should try to figure out how we can focus on history-taking approaches and that encourage the patient to tell their own story, and ways to document this patient's story that preserve the patient's narrative arc and features of the story that the patient considered of importance, while minimizing our natural inclination to reorder the patient's narrative into a medical story arc that we think fits better. This is much harder done in practice than it sounds, and it carries with it a lot of problems in terms of how we actually capture this type of information in the medical record and not just create documentation which is extremely difficult to sift through to a subsequent clinician or physician who might need to read this note. Nonetheless, these are some observations of the medical stories arc that we use in diagnosis, in how we approach thinking about patients, how we approach interviewing patients, and the considerable risks that are associated with this approach in terms of overfitting patient narratives to the limited number of story arcs that we have in our mind. I don't think it's ultimately a very good diagnostic method when you compare it to perhaps more sophisticated diagnostic techniques based off of larger data structures, larger data sets, and more Bayesian reasoning from baseline population methods. But that's a whole other topic.